This video is a breakdown of a nerve entrapment, also a fancy way to say getting stuck of the greater occipital nerve. In the video, I cover the following. What is the function of the nerve? What causes it to get entrapped? Clinical signs of an entrapment and a successful treatment process to help remove the entrapment. For those of you who don't know me, my name is Dr. Matt Maggio, and I'm a non-surgical expert in chronic pain treatment. My focus is on finding and fixing nerves that become stuck to muscles with a glue-like substance called adhesion, also known as scar tissue, and then reducing inflammation from chronic pain naturally without the use of medications or injections. This leads to a significant increase in flexibility, functioning, and long-lasting pain relief. I'm also the creator of the Peak Method, where we teach overworked massage therapists a new treatment system that cuts session times in half and eliminates the frustrations of inconsistent results so they can avoid burnout and help more people get out of pain. All right, greater occipital nerve. What is the function of the nerve? It supplies sensation to the skin along the back of the scalp and the top of the head. Some common injuries associated with dysfunction of the nerve: occipital neuralgia, migraines, tight upper traps, neck pain and tension, and cluster headaches. Occipital nerve does a lot of things, has a lot of issues, often very underlooked, especially in the role of migraines, even neck tension, headaches across the board when that nerve becomes entrapped. Another one is just cervical disc degeneration, also known as like herniations or protrusions or bulges, because a lot of times what happens is in the upper cervical region in here, if this area gets compromised, it alters the posture, things don't move how they should. So it kind of puts the head forward, which in turn puts more pressure down on the lower vertebrae, especially like the C5 to C6. And that's the most common area to have what is called disc herniations. So why do these happen? An entrapment of this nerve is actually very common due to our sedentary posture and looking down too much. The client will present with symptoms of continuous aching, burning, throbbing, and even some intermittent stabbing or shooting pain that generally starts at the base of the head and then goes up to the scalp on one or both sides of the head. A lot of times it'll just be one side or the other. It's not both sides when they're presenting with this. They might even have some like numbness and tingling when it first begins in there, but there's really three groups in the occipital nerve, that the occipital area that we look at. You got the third occipital nerve, the greater occipital nerve, and then I will see it. Sometimes it's called the lesser occipital nerve. It's also called the great auricular nerve on the side. But the most common one I do see is going to be the greater occipital nerve. That's what this whole video is about. And clients often have pain behind the eye on the affected side. The pain often presents as like migraine-like, and some clients may also experience symptoms common to migraines and cluster headaches. So a lot of times when people are having migraines and things like that, the medical system goes so extreme and they want to pump them full of Botox and give them a bunch of medications or injections, and they do all these crazy tests. They see these neurologists and they're like, we don't know what happens. At the simplest form, over time, nerves have to make their way through muscles to get where they need to go, and then they get stuck. And when they get stuck, they really get angry and they present with all this stuff. So a lot of times us as soft tissue practitioners, we need to think a little more basic. We always like freak out. We're like, oh my gosh, I don't want to treat someone with migraines. They need to see a real doctor or a neurologist. No, those people don't have a clue either. They're just going to throw them on medications or try to do surgery. It's not going to actually help solve the problem. So over here in this slide is a gross anatomy dissection of that. And you can really see where that occipital nerve comes up through here and it goes up to the base of the skull. It starts right down around like the C2 vertebrae, but usually where I catch it is like a little more midlined, especially as it makes its way up. It actually gets adhered on top runs what's called the semispinalis capitis. It's a really big muscle, one of the cervical erector muscles, and it gets stuck in between there as well. And when you feel that nerve entrapment, it almost feels like a little piece of string that's stuck. It's very tender. It's not the whole area is taut or tensioned. It's just really focused in that one area where it really just kind of stands out to you. So where would I start treatment for this? Usually what I do is I start, I go over to the spinous process of C2, and I usually go out about some thumb level out. And when I go out one thumb level, it really puts me right where that greater occipital nerve starts. If you go down one more level at C3, that's more where right along there is where the third occipital runs, but we want to start treatment there. And treating nerve entrapments can be a little bit tricky. What I find is that most providers, when they do find it, they're way too compressive. The first thing we want to do is we want to slow down and do the palpation and be able to find it. When we find it, then what we want to do is we want to go just below it and we want to get some depth into the tissue and let that tissue kind of accommodate. And a lot of times here, it doesn't need a lot of depth because it's pretty superficial to the surface. Once we get that depth, we want to back out just a little bit, maybe like 10%, because we don't want to trap the tissue. Then what we want to do is we want to set tension going up towards the occiput. So we want to be below it, depth in, back out, then set some tension and pause for a second. Then what we need to do is we need to move the client's head through a full range of motion. That's going to create some tissue slide. It's not going to pin the nerve down. So if you're too compressive within the beginning, it's just going to pin the nerve down. It's going to hurt like hell. You're going to think that you're doing something because the client's like, oh, that hurts. You must be doing something. But all you're doing is entrapping that nerve underneath your thumb and making that underneath your fingers and your thumb and making that problem a heck of a lot worse. Then the thing here is what I call there's like two types of slide when we're doing tissue slide. So we need proper depth, proper tension, then tissue slide. Most of the time we do what's called internal slide, where basically we set the tension into it and then it comes to us. I see that a lot in probably about 90% of what I treat in musculoskeletal injuries. Now with cervical spine, and this one is a little different. We do what's called external slide. So basically we start below it, and as it starts to lengthen, we need to come up and go with it and kind of track with that. So it's a little bit harder because you're trying to keep your depth and tension. You're trying to get the client to move, but you also got to move your hands as you do it as well. So that's where you go really slow, really precise, really focused so that you can actually break that down and not be in a rush. Then after I treat the neck, back not in the neck, after treating in the neck area where that greater occipital nerve first comes, is we need to actually go off and get it on the side here where it gets caught as well. So the root of where the greater occipital nerve starts is on the dorsal ramus of C2. So the way the vertebrae are set up, you have C1 and C2, and whatever is the lower listed vertebrae is the level where it comes out. So you want to be between C1 and C2, and dorsal just means it's behind. So we actually want to treat up there in the cervical plexus as we go through. This one needs very minimal depth. That area is really exposed right there on the surface. A lot of times people are way too aggressive when they go in there and treat it. Very little depth and then very minimal tension. And then it's going to be internal slide on this one where we set the tension in, we get the depth, we get the tension, and then we just have them go through that range of motion. And it's very little movement. We're really only trying to move about two segments, the C1, C2. So it's a very short, just little side lateral flexion away. In the neck, a lot of times when people are treating this, they get like way too much motion of the whole neck, and that can cause issues in there as well. You just want to be really focused in that area. Once it passes over your thumb and you feel it, that's it. You got an effective treatment on it. Next is you want to be careful in this area, treating around other structures. There's blood vessels, the jugular vein, there's the sympathetic nerve roots and chain and all that. So I've seen sometimes when I'm like too compressive or I do too much treatment in the area, it can actually give them like a sympathetic reaction. They might feel a little nauseous. They might get a little lightheaded. So this one, you want to go really slow, like do one treatment pass, chill out for about 30 seconds, do another one. Don't just go in there and hammer this area because it's very sensitive and it's a very particular area of a nerve that doesn't want a ton of treatment. It just wants the right treatment. And I always say do no more than about 3 treatment passes at the max. It doesn't need any more than that. Want to go gentle, a little softer in this area. Less is definitely a better thing than going in there and just hammering on that area. That's all I got in the video. If you got any insights, share them in the comment section below. I try my best to engage and talk with anyone that's watching these videos, share some information, learn some stuff from one another. If you like what I'm sharing, like what I'm teaching, do me a solid and share this with other providers that want to do some great work too and actually help people get out of pain long lasting and for good and not feel like you're just, busting your butt trying to get results and never really knowing what's going on. And lastly, if you like what I'm teaching, you like what I'm showing, you can go download our free training modules. The links to do that wherever you're consuming this video. We take you through a full shoulder training series that teaches you how to critically think, palpate, palpations, treatments, everything you can think of, and really helps you get on this path to being a true solutions provider instead of just being stuck in the service provider mentality. I appreciate you watching the video, and I'll catch you on the next one. Bye.